I'll do a quick boom and bust on spinal navigation. Here are my disclosures. Not going to go, Paul did a nice job on just the history of where we've been with navigation to where we're going. And we've been using it at Cedars since 2007 in a lot of different cases and a lot of different applications, and we're truly all in. But we didn't get there. There were a lot of busts along the way. And those busts include workflow. Workflow is now a normal vocabulary that we use for all new technology, but spinal navigation really hit us spine surgeons because it was a multi-systems, multi-team technology. And compared to fluoro, where it was just a radiology tech and a scrub tech, it really involved a lot more people than just the surgeon. And it required proficiency of all team members involved. And that's something we learned from the busts. And so we saw this in the learning curves. We saw that initially everyone adopted navigation because it was so cool to see deep bony anatomy and be accurate. But if you kept switching out your navigation team, people weren't there, coordination was difficult, you started doing more complex cases, you see this drop in your workflow and ultimately poor outcomes and a discarding of technology. So what we learned with this technology and all new technologies in the future is there's a supreme amount of emphasis on workflow in order to achieve a proficiency and adoption beyond where you started. But it truly was an interesting bust. Another one that Paul points out, and as you point out, Jens, as we talk about this, is the static tracking concept. It's currently the biggest problem with navigation, and it's the result of what we call at Cedars phase shifts. And you see this where you lose the accuracy, the reference frame gets either bumped, touched, blood on the spheres, and you trust the navigation implicitly, and that ultimately leads you to put screws in where they shouldn't. These are all published data. We found that in this bust, there was unintentional and intentional losses of registration. The unintentionals were those reference frame bumps, blood on the spheres, as I mentioned, instrumentation failure, joysticking or deflection of the spine, kind of cannulating pedicles, Linky style, whereas it's a much more finesse kind of procedure. Intentional, as we put in interbody cages, as Paul pointed out, these are intentional losses of registration. There's no way for navigation still to the current date to correct this, and that's a problem. And as I said, all these can lead to pretty poor outcomes. Paul touched on radiation exposure. That's another bust. From an occupational standpoint, this is us at Cedars. This is the O-arm coming in. This is everybody leaving the room. And ultimately at the final spin, no one's in the room. And from an occupational standpoint, that's pretty minimal. The manufacturer teams have done well in reducing from one generation to the next, the amount of X-ray delivery. And really the question is, how accurate or detailed does the CAT scan need to be to put a 6.5 screw in a 7.5 hole? A lot of this is driven by the pediatric literature. Noelle Larson has looked at this a lot as to how much do you really need, and she has driven it down to one O-arm spin, or one CT acquisition spin, equivalent to about 6 or 7 chest X-rays. So that's pretty encouraging. And then another 50-patient randomized controlled trial looking at these low-dose protocols. And what they achieve is near equal accuracy with a nearly 5-fold reduction in radiation. So certainly radiation exposure to the patient is there, but as we trust technology, we'll get better, and there's actually more in the future. Cost effectiveness is another bust of navigation, as it is with robotics and other new technology. When you look at a $1.25 million capital expense, that's hard to swallow as a hospital administrator with no additional reimbursements. Charles Fisher and the Canadian group did a great job in looking at navigation CT compared to fluoro, and found that navigation did do well in terms of accuracy and revision, and found that it is cost effective if your center does about 168 instrumented spine cases a year. And so year over year, you're seeing less revisions, less symptomatic instrumentation, ASD revision surgery, post-op imaging, shorter length of stays. And so this does tend to be cost effective. Intangible costs, marketing, as well as these younger surgeons, as we train them all, as Paul does, as we do with our fellows, younger surgeons are demanding it. And so hospitals have to pay up. And so they're getting these new technologies because it translates into patient safety. And that's what's most cost effective long term. So let's go into the boom. Navigation has truly excelled my career in terms of being a better spine surgeon. It's an enabling technology that has really allowed me to do things that were originally in concept into the operative theater. Here's a complex clipple file patient, previous laminectomy as a preacher with cranial settling. And this is both a decompression and a stabilization type procedure, but a lot of limited anatomic structures to key off of. And with navigation, this approach was very straightforward. We were able to do a subcranial, suboccipital craniotomy, get our decompression, get our plate. This is the longest C1 lateral mass screw that the implant companies make. And to get that instrumentation done was a big boom. Here's another one, a common case that we see with chin on chest back in the day, C2 to 7 fusion, drop head. And what you see on this CAT scan is that after a week of gentle traction in the ICU, we get the patient to a more reasonable position. But again, previous laminectomies, fusion mass with no anatomic landmarks. Navigation was able to allow us to not only get these lateral mass screws across fusion masses, get pedicle screws in, but also distally get us to a stable construct with excellent clinical outcomes year over year. I've done this scoliosis surgery freehand, fluoro, and navigation. Truly, navigation has really improved the way that I do scoliosis surgery. Again, this cross-section video of all these lanky C and D pedicles, atretic, no big cortical margin, and being able to, normally, I think traditionally without navigation, we would have skipped those. These are typically at the concave portion of the curve where you need it the most. But improving on that implant density in my hands is translated to 5 years of good durable follow-up in both the coronal and sagittal plane. And what about these degen spondies? All these cases and all these techniques presented today can be improved upon with navigation. This is one that you revisit in different ways, in different forms, with different technology, but navigation seems to really allow you to do a 2-level Wiltse, plan your incisions very well intraoperatively, get down to your area of where you need to do your facetectomy, your osteotomy cuts, your decompressions, and then ultimately putting in your interbody cages and making this an outpatient procedure, whereas before it was not. And then multiplying this by a couple levels to an MIS-Scoli. This has been extremely helpful, as Paul has pointed out, so I won't dwell on that too much. Taking neurosurgeons, neurosurgery fellows through pelvic screws has been a joy, less than a challenge. It's more as a contest to really have them understand, but also shoot the longest pelvic screw that they can to match our constructs, and that has been helpful. And then when you look at navigated tumors, this has been instrumental in resection. This is a lady with a renal cell carcinoma that we did a hemisacrectomy, excuse me, and a lumbosacral reconstruction with sacral transbar. All navigation, very helpful. So the last minute of my talk is really the future of navigation, and that's really where we're headed. Navigation is the platform for all technologies in the future, and you heard it from me first. Robotics is using it, and we're using it for navigation. Robotics, it's the GPS map that a lot of our technologies will key off of. Paul sees this problem as we all do. This is a no boom, where you have a black and white picture of a lateral axis. And the demand for soft tissue navigation is there, whether it's for indirect decompression, lateral disc herniations, endoscopy. It's there. So why can't you? You do it in cranies to navigate MRI. Why shouldn't that be there for the spine, for laterals, for docking, and ultimately, why can't we merge this together with our CT scans to get a black and white and a technicolor approach. And so I think that's pretty encouraging from navigation. And certainly the role of optical tracking. And I have a Tesla now, and I trust my life with it. It's very accurate, all based on optical tracking and laser. We trust our security in our iPhones with optical tracking, and that technology is here for navigation. Converting it, instead of a one shot of a patient on a table with an intraoperative CT scan, sounds kind of archaic. To be able to do it with some form of light projection where you're able to map out the topography. So that issue that we all encounter with navigation where the reference frame is accidentally bumped and you get an net accuracy loss in your navigation, and then you would have to respin. What this light technology allows is for you to reapply the reference frame with a single burst of light, refix and recalibrate your instruments and get your accuracy restored. No more loss of registration. If you lose it, if you're dealing with a dynamic situation like Paul's, you don't have to repeat spin, and there's absolutely no radiation exposure. So at the end of the day, the future of navigation is bright. It's not done. There's been incremental improvements in the bus. There have been major developments on the booms. And when the underlying goal is for patient safety, it will stay with us forever. So I really encourage the residents and fellows who are watching this, if they don't have this at their institution, to go to courses, because it will be a part of their gold standard in the future. Thank you.
Thank you, Terrence. Fantastic, quick, and to the point, and I thought very balanced, also with a lot of good tidbits as to what to watch out for in the first half. You're Director of Education at Cedars-Sinai. Here's a whole bunch of young surgeons here in this institution who still put up with dinosaur surgeons like me, and I'll put Rod into that bag also, because they actually, in part, told me that they came here because they want to learn how to put in pedicle screws. They actually wanted to ask whether they'd use more traditional means versus navigation or not. Should we teach the next generation how to put it in with traditional techniques first, that they develop the proprioceptive feedback and touch, or should we just basically say, look, technology is here to stay, and let's just open up the door for new technologies and put away with the old traditional techniques?
We've had discussions about this because it's critically important that they learn the correct way, and your way, Rod's way, is the correct way. You gotta do it first by doing it everything freehand or with fluoroscopy. There are times where the O-arm isn't available. I'll have to say on the weekends or at nighttime with the trauma case, and so we switch back to freehand or fluoro. But ultimately, I think if you dabble in this new technology, as every surgeon has today, you learn about adoption of this technology, and that's what I try to focus on with our fellows as well. Is just don't jump into things. Here's all this new technology that we're going to throw at you. We're trying to push them to a learning curve that's past that initial mistake, and kind of get them to a place where whichever technology they assume they want, they can excel at. But I can't express enough how important it is not to trust navigation implicitly, and how to have common sense and to know your anatomic landmarks. And that's absolutely something you guys do a great job of doing.
So I loved hearing of your surface scanning technology. It's something kind of we've played with around in a much lower tech version. It's great to see this in clinical applications now. How much exposure do you need for that to actually work? Can you put an elegant tubular technology actually into this kind of a sphere where you have a surface optical scanning, or is that highly dependent upon having an open exposure?
You know, when that optical company came around, I thought it was going to be the next thing since sliced bread, you know, and they do require still for optical exposure of the lamina, the bony lamina, and something deeper to match the topography to navigate it onto the CT scan. So it's not perfect. It quite hasn't taken off yet, but the fact that that technology is used elsewhere in auto and other areas, there is no doubt that that's going to be an easy one, especially for the dynamic tracking capabilities that we need at the moment.
I'm going to ask Paul if he's still around to join us. Paul and Terrence, both of you have shown mastery in applying modern technology for a safer patient application. Now, what I see in clinical reality is where these technologies are more enabling technologies, and surgeons who may have not been trained in more complex surgeries use these technologies and have kind of done dangerous things to patients that I think all of us would agree on are kind of very questionable. So where's the boundary of enabling technologies so that we can make sure that surgeons who use them are relatively safe for them and use or pair good judicious expertise with technical execution?
Well, I'm not sure what Terrence is going to say, but that's actually a very good question because, you know, if you take navigation at face value, there are surgeons who didn't do spine surgery because they were maybe afraid of pedicle screw placements. Now that they can fairly easily, and I've seen this, will do so without understanding some of the biomechanics of the spine. And they may instrument improperly or do a procedure that's probably not warranted. So I don't know if I have the right answer to that because the technology is available and so they'll be able to use it. I think it's something where we need to continue to educate, I think, surgeons on what the best indication for an operation is, for example. If you look at outcomes, and this is maybe becoming more of a general discussion, is your best outcomes come not maybe from your technique, but picking the right patient and treating the right condition more than anything else. And I think that's a key, I think, toward having the best sort of outcomes is actually seeing the patient, figuring out what's wrong with them, and developing potentially the right treatment. And then if enabling technologies allow you to do that's the optimal way to do it.
So we need a Tesla, Elon Musk autopilot to basically tell us don't operate on this patient after having a facial recognition interview with a patient.
Right, right.
Jens, I'll tell you that every new technology has a different learning curve, and I think that's the important lesson that we all have to learn. A standard surgical procedure is pretty linear. The more you do, the better you get. Navigation was probably one of the hardest workflows that I think I've seen, and I haven't seen that much, only 12 years of spine surgery. But that dip of that learning curve that I showed you, that's going to come up with a different technology. We see in robotics that the learning curve is actually pretty quick and adaptable. And reproducible. So I think it's for the surgeon to really kind of understand what's going to take a lot of effort to get it right, and maybe a combination with industry and experts to just be like, this is a technology that needs more than just a cadaver lab. This is one where you're going to need to be proctored. You're going to need to have support so that you don't make those mistakes, whereas others won't. And I think that's the little subtleties that with new technology.
So this, if I hear you right and extrapolate this one step further, would be kind of a step towards having a certification process that's not just a courtesy weekend course where you actually have to prove your capabilities. Paul, do you agree with that? There might have to be a step towards certifying beyond graduating from a fellowship or taking a weekend course towards kind of having good, safe application of enhancing technologies?
Yeah. Yes. Well, I would say yes in a more broader sense too. I mean, I think right now, even for deformities, and I'm just going to use that as an example, we're seeing a lot of massive operations potentially for maybe the wrong indication. And it's what I said earlier. I think in general, spine is unpoliced, and you can do whatever you want. And I think these days it's not just navigation, but other devices, instrumentations, those are all enabling options for surgeons. And now people are just doing massive operations sometimes that are unwarranted. So I would agree just in principle with you. I think in some ways we need more of a certification process before you go out and become a spine surgeon, I think.
Yeah, no, this is an interesting topic because I referenced the NHS project, the Getting It Right the First Time initiative, and they have a national database, and they unequivocally showed that the complication rate of spinal deformity drops dramatically once you do more than 50 procedures in a year. So that's a very interesting number, and that fits to Jim's and David's amazing concurrence. You should have been there last year. They're bashing their heads in here when they're live. And on the Zoom environment, they're all very, very nice, but they also basically made a plea for having spinal cord injury patients being treated in tertiary care centers. So this is an interesting perspective. One more question to pick up on what Terrence and Icy pointed out, and that is the workflow thing. So in your OR environment, do you now have a tech standing by, a IT specialist in the OR to help augment the various media with one another? And who provides that? Is that a hospital or is that a industry provided FTE?
Tale of Two Cities. The navigation was kind of more frontier and unknown. And so we developed everything, and the microscope cleaners, the ones who go around the hospital and clean microscopes, put away the endoscopes and stuff, we upgraded them to what we call image guidance techs. And so they now run the software, they run the machines, and they bring them in, and the reps provide support. The other Tale of Two Cities is the robot. The companies are providing these robot expert technicians that are not MDs to be there at every single case. And they provide, this is provided from the manufacturing company to kind of flatten that learning curve. And I find that super interesting. I don't know how long it's going to last, but that's been an amazing kind of evolution in the way the industry has tried to deal with this, because we're in it together. If we have a bad case, they have a bad case. And so I found that to be extremely useful.
And Paul, maybe close us out with a observation from you. And so workflow has been one of those big things. I heard from Dr. Kim that at night, for instance, trauma cases, they may not use their modern technology. How's that with you guys? Is workflow an issue, and the after-hour weekend cases, are they a problem?
That's a great question. And workflow definitely is a key factor in terms of time efficiency. We've seen that with new technology. The robot, for example, we got a robot a couple years back, and it took us twice as long to do a procedure. And a large part of that was our workflow. And we've got that down quite a bit. And in our institution, the hospital actually has really put the resources in place. We have techs available at all hours. So that's not the issue. So it's possible to use our technology at any time of the day, 24/7 essentially. Having said that, I agree with, I think, Terrence. I think our trainees, the residents, need to know how to put screws in freehand and do the procedure without technology, because I think there's a learning component to that. I think sometimes technology, if you just use it exclusively, will handicap you as a surgeon. So I think training should do both.
So I think we're on time. This was a true highlight, ending to a great, very full information-packed day. Thank you both for your excellent lectures and question and answer session. And I'll ask our course chair and the originator of this whole thing, who's up to no good, as I'm seeing, Dr. Robotics, to lead some final concluding words. And Terrence's partner, Dr. Patrick Johnson, he gives a great lecture on thoracolumbar trauma. Please activate the link and take a look at his lecture.